May I invite Dr. Sreekumar, please, now?
Dr. R.C. Babu, usually the vascular surgeon. Now we are talking about different subject today.
Thank you, sir. Very good afternoon to all. I congratulate my friends and thank the Kottayam friends, Dr. Binni, Dr. Injin, and Dr. Bibin for the wonderful conference, and also for taking general surgery to its past glories, where we move out of the abdomen. In previous years, Kasicon means mostly abdomen, but we are in the yesterday workshop also. We have seen a lot of procedures out of the abdomen. So we are discussing a new procedure which is quite familiar to a few people, but it's a very simple procedure but benefits many patients. Something which we think beyond the belly. Can we do something for our patients outside the abdomen? That's a question. First, it's an irony that I'm talking about such a topic, which is the second level of chest injury. And in a weekend, at least a week back, we lost a life, precious life. Maybe due to it's a controversial subject, but at least to be due to failure in putting an intercostal drainage too. So now we are thinking about a next level of. Let us start with a story and a video. This Mahout and the Tusker had a fight, probably under the influence of alcohol of both, and he was heavily and massively injured by the Tusker by multiple attacks. He is only a 26-year-old male and who was with this elephant for many years, and ultimately he was taken to our casualty with multiple injuries. The injuries consist of the fracture of one side of the chest completely with a massive splenic injury and a pelvic fracture. So he had injuries of the ribs from 3 to 11 and a hemiperitoneum for which a medial splenectomy was done, and fracture pelvis was managed conservatively. This patient was put on a chest tube, intercostal drainage tube, and is extubated on the third day and shifted out of the ICU by fourth day. But he has severe chest pain affecting his routine respiration, and we could not maintain the saturation even with oxygen. Sometimes he is put back to an AV. So the question is what to do. Can we send back the patient with an advice that take deep breath, take some exercise, spirometry, and take some analgesics and come back? Or can we just the patient leave alone? So all the options are fixed or thought of. Then we thought of why don't we try chest wall fixation. So we had decided to put some plates and screws on him, just like an orthopedician. And in fact, he had injury from, I said, almost 9 ribs are injured. So we need at least 6 or 7 plates, which is quite costly. And patient could not afford a single one. So due to different schemes, I could mobilize the cost for only 2 plates, which is cut into 3 pieces so that I can have 4 plates only. So we got a reduction with the chest is open in a vertical incision along the line of fracture, and all the ribs were correctly aligned with the help of Alice forceps and further devices. And we have fixed the fixation done for 6, 7, 8, and 9 ribs, so that almost a respiration is possible. So he is extubated the next day, and physio started on the second post-op day. He is maintaining maintenance saturation even without oxygen, and he is discharged after a week, and he is quite active and healthy. So second case is a staff in the secretariat. It's a 45-year-old woman who doing his office work. She had a scooter injury on the road. She was taken to a hospital, and she was again managed conservatively. But after a week, she says she has severe pain. She could not do his routine office work, or she can go back to his office. So again, she was discharged with advices to come after some 2 weeks again. But she came back after a week with severe pain, which lot of issues were. Again, we had the same procedure done, and we fixed the chest, and she went back to office, and she's quite happy about it. Totally, we have done around 5 cases, and all of them are excellent results. So there are certain indications, prescribed indications for chest wall fixation. That is, flail chest is an absolute indication, but I could not do a single case. Even though I worked out 1 case, I lost the patient just before the patient is taken to theatre due to severe flail chest. So it's an absolute indication for doing it. Or when there is more than 3 fractures, 3 ribs are fractured at bicortically identical sites, or when you see any paradoxical movement. So, and failure to wean out of the ventilator in a patient with fracture ribs is another indication. Other indications are, again, patient is going for a thoracotomy and we expect a severe pain after that, then still we can do it. And if the chest volume is congenitally less than 30%. There are definitely few contraindications. One is if the patient is in severe shock with other massive injuries, head injuries or abdominal injuries, this is not ideal procedure. And if there are fractures between the first, second rib or 10, 11, 12 ribs also, that's not ideal situation. And if the patient has severe traumatic brain injury or patient post-traumatic myocardial infarction, it's absolute contraindications. There are later contraindications like extremities of age where the bone growth is not completed, or there is severe cardiopulmonary comorbidities or a head injury, spinal injury, empyema, etc. So there are certain advantages for this procedure. Definitely in our patients and almost all the studies agree that the ICU stay and the in-hospital stay can be considerably reduced by this procedure, and mechanical patient can be out of it later at the earliest doing this. And pneumonia is also less, particularly post-traumatic pneumonitis can be reduced considerably in most of the studies. And tracheostomy requirement is also less. And there are some controversial reports regarding whether it effectively reduce the mortality or not, but some studies give a slight edge regarding the mortality. So imaging is a must for doing this procedure, and a chest X-ray is not adequate. We need a right CT chest with a reconstruction of the ribs. Question is, do we offer this procedure to all patients? The study says if you are not doing any procedure and just leaving the patient with the fracture ribs, even the single one or two fractures, 29, that is 1/3 of patients will fail to go to duty, return off because continuous pain even after 2 years. That's a huge number. And 64% of those patients with chest injury have post-traumatic chest pain even after 2 years is published. The question is when to do it. The time starts at the time of trauma itself. If you do it early, the results are better. So it should be performed ideally within 48 hours and preferably within 72 hours. So after that, results may not be good. But I was forced to do the procedures even after that time frame. So if there is any other injury or a massive head injury or chest injury or other abdominal injuries, we can delay it so that we can plan later. In a ventilated patient, again, he has to do it within 72 hours of the patient is failed to. So there are clear algorithms for that. There are many systems are available, but I use the anti-plating systems. It's anterior plate I used. Other systems, I don't have any experience. There are certain complications, just like any other procedure of any trauma, anesthesia complications, because we need a chest procedure. Infections are possible, and sometimes the plates may fracture. Advantages are many. It will reduce pain, it will respiratory outcomes better. There is cough may be better in the post-op patients, less ICU and hospital stay, and ultimately, if you look at the cost, if you think the cost of the ICU stay and the in-hospital stay and the cost due to not going back to work, it is comparatively much higher than the cost of doing this procedure. So the study says primary performing surgery, if you do it at the earliest, that gives a better result, better outcome, and it is one of the most cost-effective treatment known today. So the question is, there are studies, early fixation within 48 hours or 72 hours, which gives a very good results. Please don't forget, this is a very common, fractures are very common in thoracic trauma, and most of them we are managing conservatively, but they have long-term morbidity and we have mortality. So the study says selective few has a better outcome from fixation. So as a surgeon, as a general surgeon, as a traumatic surgeon, we should offer it to all our patients. Please remember, this is not a very complicated procedure. This is almost a simple procedure. Cost of treatment is much less than the cost of conservative line of management. Results are better, shown by many studies. Never it is worse comparing the conservative line of management. So you should do it. Failures may happen, but always we should be happy with our results. Thank you for the presentation.
What's the role of thoracic epidural or intercostal block? Should you try it as the first line?
Thoracic epidural is a short term, so we can give over 1 week. We are looking at that gives maybe the pain may be reduced for a period of 1 week, but that will not give a long-term results. Here, the procedure will give a long-term results. The pain will be completely alleviated.
Can it avoid ventilation?
Yes, all the 2 patients out of ventilator next day. The first patient was ventilator, INAV, ventilator, NAV, but that stopped after this procedure.
No, do you think that thoracic epidural can avoid ventilation?
That I didn't try. This patient undergone ventilation because of trauma and surgery itself.
That's an excellent and brief talk. I would doubt. Why can't you treat this patient with excellent anesthesia? Usually, rib fracture treated by excellent anesthesia, intercost block or epidural anesthesia. Most of the case, you would be able to treat with a good intercostal block or epidural anesthesia. This is the thing about cost effect, concern cost effect. My personal opinion is adequate analgesia and restoration of the respiration. That is the principles of chest trauma.
Sir, that's a line of, I agree that that's a line of management the first 48 hours or 72 hours or a week. But the study says even after this 2 years, patients have persisting pain. We are not addressing to it. So this procedure addresses to that long-term issues.
Good afternoon.
Yes,
Good
from the
evening, sir.
audience.
Good evening, sir.
So, most of surgeons treat in trauma. And there are a
yeah.
lot of comments.
We are also having an experience of doing about 9 cases, and we do combine these patients with thoracoscopy along with hemothorax, whatever is there, which is removed. And 2 cases we found in a accidental diaphragmatic injury, which was again repaired. And what, as compared to what sir says, the chest wall instability, that is the one which can be corrected by rib fixation. That gives the long-term better result.
Sir,
What's your opinion?
when we open the chest after a week or so, most of the ribs are just like that reduces lung volume by 30%, 40%.
Last comment, sir, please.
One practical doubt. The patient might be having an intercostal drainage. Would you remove the tube before you plan for the surgery?
No,
or
no.
will you persist with the tube?
We'll keep the tube. We do the procedure with the tube because the tube is going in between. We can put the tube there. We can keep the tube. After the procedure, when the patient is back to normal, we can remove the tube.
Is there a higher incidence of infection because of that?
Till not, it's possible.
Thank you, sir. Can we move forward, please?
Okay, then we will go to the next speaker.